Bismillahirrahmanirrahim. In quote for the day is, if you are grateful, I will certainly give you more. The topic for today's presentation is diabetes mellitus. I am Dr. Ayesha MellitusPresenter of FCPS Community Medicine at Institute of Public Health, and I will be presenting this under the kind supervision of my professor and teacher, Professor Dr. Saira Afzal, who is the Dean of IPH Lahore. The learning outlines for today's presentation would be introduction, classification of diabetes, risk factor for diabetes, epidemiology, diagnosis and management, prevention, recent updates, and multiple choice questions. Learning outcome. By the end of this presentation, the participants would be able to describe diabetes mellitus, that's epidemiology, types, screening and prevention, and to be able to answer the multiple choice questions. Introduction. So, diabetes mellitus is a common chronic metabolic disorder which is characterized by persistent hyperglycemia resulting from defects in insulin secretion, insulin action, or both. Insulin, which is a hormone produced by the beta cell of pancreas, play a key role in regulating blood glucose level by facilitating the uptake and utilization of glucose by body. Insulin is a hormone that regulates blood glucose. Hyperglycemia, which is called as raised blood sugar or raised blood glucose, is a common effect of uncontrolled diabetes, and over the time, it leads to serious damage to many of the body systems, especially the nerves and blood vessels. So, diabetes is a major public health challenge worldwide associated with significant morbidity, mortality, and economic burden, with rapid urbanization, sedentary lifestyles, unhealthy dietary patterns, and population aging. Particularly in low and middle income countries, the prevalence of diabetes continue to rise. So, what are the risk factors for diabetes? There are certain non-modifiable and certain modifiable risk factors for diabetes. The non-modifiable risk factors are increasing age, more than of 35 to 40 years of age, family history of diabetes. If there are first-degree relatives for diabetes, there are high chances for getting the diabetes, genetic predisposition or ethnicity, especially it has a higher risk in South Asian population, history of gestational diabetes mellitus, low birth weight, or intrauterine growth restriction, or polycystic ovarian syndrome, they can all lead to diabetes, while certain modifiable risk factors are overweight and obesity, especially central obesity, physical inactivity or sedentary lifestyle, unhealthy diet which constitute of high refined carbohydrates, saturated fats, and sugary drinks, hypertension, dyslipidemia, especially high triglycerides level and low HDL levels, smoking and tobacco use, excess alcohol intake, and chronic stress. The classification of diabetes. The diabetes is classified into the following types. The common types are type 1 diabetes mellitus, type 2 diabetes mellitus, gestational diabetes mellitus, iatrogenic diabetes mellitus, hybrid diabetes mellitus, and other specific types, which includes monogenic diabetes mellitus, disease of exocrine pancreas, and certain endocrinopathies. We will look into the detail of all these types one by one. So, what is type 1 diabetes mellitus? Type 1 diabetes, which was previously known as insulin dependent diabetes mellitus or the juvenile or childhood onset diabetes mellitus, is characterized by the relative or absolute deficiency of insulin production, and it requires daily administration of insulin. The causes for type 1 diabetes mellitus are again the hereditary predisposition, certain autoimmune diseases, viral and certain viral infections, autoimmune destruction of the beta cell of pancreas, damage or removal of the pancreas, unfavorable environmental factors, certain drugs and chemical toxins, and endocrine disease can lead to type 1 diabetes mellitus. The symptoms of type 1 diabetes in adults and children. The common symptoms of diabetes are excessive thirst, which is polydipsia, excessive hunger, which is polyphagia, unexplained weight loss, blurred vision, slow healings of cuts and sores, fatigue, vaginal yeast infection due to low immunity, and frequent urination, which is known as polyuria. Type 2 diabetes mellitus, it is characterized by the resistance of body cells to use insulin, It stops the body from using insulin properly, which can lead to high levels of blood glucose. So in type 2 by diabetes mellitus, they are basically the insulin, pancreas are releasing the insulin, but the cells of the body, they have the resistance, or they are unable to use the insulin. So the risk factors are again the same: fatty liver, medication or hormonal diseases, increased lipid levels, obesity, unhealthy diet, lack of physical exercise, depression, gestational diabetes mellitus, type 2 diabetes mellitus in family, old age, high blood pressure, and again smoking and alcohol use. So what are the effects of type 2 diabetes mellitus of the body? It can lead to the confused thinking, dry mouth, wounds slow to heal, burning or tingling sensation of the feet, irritability, feeling hunger, fatigue, unintentional weight loss, urinating excessively, inflamed or red gums, and feeling very thirsty. So the major differences between the type 1 and type 2 diabetes mellitus is type 1 is juvenile onset. It has autoimmune or genetic causes. In type 1 diabetes mellitus, there are no functional pancreas or no insulin production. It cannot be prevented and it cannot be reversed. While the type 2 diabetes mellitus is basically of adult onset, and in it insulin resistance is present. Obesity or aging can lead to this. Partially functional pancreas are there in type 2 diabetes mellitus, due to which some insulin is produced. It can be prevented through lifestyle changes, and it can be reversed by early diagnosis. The common symptom between both the diabetes are is the presence of thirst, frequent urination, and blurry vision, and they all required lifestyle modification and medical supervision, and they both can lead to complication if they left untreated. So in this part of the figure at the right side, you can see that in type 1 diabetes mellitus, there is no insulin present in the blood. While in type 2 diabetes mellitus, the insulin is present in the blood, but the cells are their receptor, they become resistant. So insulin is unable to bind to the receptors and it cannot move into the cell. So basically, cells are resistant to use of insulin. Coming to the gestational diabetes mellitus, the gestational diabetes mellitus is hyperglycemia with blood glucose value above normal but below those diagnostic of diabetes. And gestational diabetes occurs during pregnancy, and it is the diabetes basically which is diagnosed after the 20th week of the pregnancy. So the risk factor for gestational diabetes mellitus is high blood pressure, heart diseases, family history of type 2 diabetes mellitus, personal history of gestational diabetes in previous pregnancies, having obesity or overweight before pregnancy, increased maternal age over 35 years of age, pre-diabetic patients, or polycystic ovarian disease. There are no usually obvious warning signs for GDM. If you do have, that may include frequent urination, nausea, excessive thirst, and tiredness. So the GDM is mostly diagnosed on the test that is OGDT, which is routinely performed by the obstetricians. So gestational diabetes mellitus, it can lead to type 2 diabetes mellitus, preeclampsia, the factors which contribute: macrosmia, cesarean delivery, reproductive disorders, breast cancers, maternal depression, neonatal jaundice, and ovarian dysfunction. The next type is iatrogenic diabetes mellitus. The iatrogenic diabetes mellitus refers to the diabetes or hyperglycemia which is induced by the medical treatment or intervention, most commonly due to the drugs that interfere with insulin secretion, insulin action, or glucose metabolism. The common drugs which leads to diabetes are glucocorticoids, mainly prednisolone or dexamethasone, thiazide diuretics, which include hydrochlorothiazides, antipsychotics, especially olanzapine, clozapine, immunosuppressant, including tacrolimus and cyclosporine, certain hormonal drugs, including oral contraceptive pills. They are diabetogenic and growth hormone. The hybrid diabetes mellitus, it has its nomenclature is now changed. Previously, it was referred to as latent autoimmune disease of adults, that is LADA, slowly evolving immune-mediated diabetes of adult, similar to slowly evolving type 1 in adults, but more often has features of metabolic syndrome, a single CAD autoantibody, and retains greater beta cell function. In monogenic diabetes mellitus, there are two kinds of monogenic diabetes mellitus. The first one is monogenic defects of beta cell function, which is also known as maturity onset diabetes of young MODY. It is caused by the specific gene mutation and has several clinical manifestations requiring different treatment, some occurring in neonatal period and others by early adulthood. While the second type is monogenic defect in insulin action. It is also known as insulin resistance syndrome. It is caused by specific gene mutation, has feature of severe insulin resistance without obesity. Diabetes develop when beta cell do not compensate for insulin resistance. The next is disease of exocrine pancreas. Various conditions that affect the pancreas can result in hyperglycemia. So the disease of exocrine pancreas, which can lead to diabetes mellitus, is chronic pancreatitis, pancreatectomy, and pancreatic carcinoma. They can all lead to increased glucose in the blood. While other endocrine disorders which contribute to diabetes mellitus, it occur in disease with excess secretions of hormone that are insulin antagonists. So endocrinopathies which lead to diabetes are Cushing syndrome, which is basically the disease of adrenal gland, acromegaly, which is basically due to the over secretion of growth hormones, and pheochromocytoma, which is basically the tumor of adrenal medulla. So, coming to the screening of diabetes, who should be screened for diabetes mellitus? So, according to the American Diabetic Association, asymptomatic adults with a body mass index of greater than 25 kilogram per meter square and one or more of the following risk factors, they should be screened: HbA1c of greater than 5.7%, impaired glucose tolerance, or impaired fasting glucose on previous testing. Cardiovascular diseases, first degree relatives with type 2 diabetes mellitus, HDL cholesterol level of less than 35 mg per dl, or a triglyceride level of greater than 250 mg per dl. High risk ethnicity like Black American, Native American, Asian Americans, Hispanic, hypertension, blood pressure of greater than 140 by 90 millimeters of mercury, or any person who is taking a medication for hypertension should be screened for diabetes. Physical inactivity, polycystic ovarian syndrome, women who had gestational diabetes or who had delivered a baby weighing more than 9 pounds. In person without the risk factors, testing should begin at 45 years of age. If tests are normal, repeat testing should be performed at least every 3 years. These are the guidelines by the US Preventive Task Force. So according to this, what does they recommend? They recommend that adult age between 35 to 70 years who have been overweight or obese, they should be screened for diabetes. To whom this recommendation is applied: so non-pregnant adult, basically between 35 to 70 years of age, who are overweight, they should be screened, and who don't have the symptoms of diabetes. So now what is new? They have lowered the age limit. Now the recommendations are that screening should be started between 35 to 40 years of age. How to implement these recommendations? Obtain height and weight measurement to determine whether the patient has overweight, obesity. Overweight and obesity are defined as the BMI again of more than 25 and 30 respectively. So screen if the patient is between the age of 35 to 70 years of age and is overweight or obese. Consider screening at an earlier age. If the patient is from a population of disproportionately high prevalence of diabetes, as we have already discussed, if he is an American Indian, Alaskan Native, or South Asian, and a lower BMI of greater than 23 degree if the patient is Asian American. Screening tests for pre-diabetes and type 2 diabetes include measurement of fasting blood glucose or HbA1c level, or an oral glucose tolerance test. The optimal screening interval for adults with an initial normal glucose test result is uncertain, so screening should be repeated every 3 years. So what are the other relevant recommendations? The USPSTF has made a recommendation on behavioral weight loss interventions to prevent obesity-related morbidity and mortality in adults with a BMI of greater than 30 kilogram per meter square. Screening and diagnosis. Following tests are performed for the diabetes mellitus: urinary glucose, fasting blood glucose level, random blood glucose, glycosylated hemoglobin or HbA1c, and oral glucose tolerance test. So blood test for diabetes mellitus is the diagnostic, the test which is commonly used for diagnosis is HbA1c. So if the patient has a value of less than 5.7%, it is considered as normal, while if it falls between the range of 5.7 to 6.5%, it is pre-diabetic. And if the levels are greater than 6.5%, the person is labeled as diabetic. So the HbA1c test is usually made the average blood glucose for the past 3 months. Fasting blood glucose, fasting means that a person is not supposed to anything to eat or drink except water for at least 8 hours, and then the test is usually done first in the morning before breakfast. So if the glucose level are less than 100, that is considered as normal, while if the test range falls between the 100 and 126, it is considered as pre-diabetic, and if it is more than 126, the patient is considered as diabetic. These are the reference values according to the American Diabetic Association. The random blood sugar test. This test is a blood check at any time of the day. So diabetes is diagnosed at a blood glucose of greater than or equal to 200 milligrams per day. While the OGTT, it is usually that is oral glucose tolerance test. It is usually performed in pregnant females, and it is a 2-hour test that checks your blood glucose level before and 2 hours after the patient is given of a 75-gram glucose drink. It tells us how the body processed sugar. So if the values are less than 140 mg per dl, it is considered as normal, while if it is the levels are between 140 to 200 milligram per dl, it is considered as to be pre-diabetic, while the levels of greater than 200, the patient is labeled as being diabetic. The other tests which are routinely performed in the diabetes are urine complete examination, renal function test, fasting lipid profile, eye examination, that is retinoscopy, and echocardiography. The management of diabetes revolves around lifestyle modification and oral hypoglycemic agent and insulin. So the lifestyle modification includes lifestyle and dietary change of habits. So the patient are asked to have healthy eating habits, regular physical activity, blood sugar monitoring. They should stay hydrated. The compliance to medication is very important. Weight management, stress management, and avoid alcohol and smoking consumption. So the food of the diabetic patient, it should include fish, cheese, salads, water, green juices, fresh fruits, low carbs, sugar-free ice creams, red meat, vegetables, burgers without bread, especially the white breads, and red wine and spirits, while the person should not consume snack, fried foods, processed foods, bread or bakery products, sweets and ice creams, cakes, processed meat, pasta, burgers, fries. The processed or high carb diet is basically not indicated for the patients of diabetes. The drugs, the oral hypoglycemia, the most common drugs which are used are biguanides, metformin, and this first and second generation of sulfonylureas, including glibenclamide, glipizide, glimepiride, while other drugs are maglitinide, thiazolidinenoids, alpha-glucosidase inhibitor, incretin agonists, and DPP-4 inhibitors. While for the insulin, we have different types of insulin. We have bovine human recombinant, while there are certain other preparations which include soluble insulin or plain insulin, then rapid-acting insulin analog, which includes insulin lispro and aspart, and prolonged-acting insulin, which includes protamine insulin, zinc insulin, and glargine. Coming to the complications of diabetes, the diabetes have macro and microvascular complications. The macrovascular complications includes the brain, heart, and extremities. So it can lead to the cerebrovascular accidents. In heart, it can lead to the myocardial infarction and the risk for the coronary heart diseases. And in extremities, it can lead to the peripheral vascular disease, which result basically from the narrowing of the blood vessel, increasing the risk for reduced or lack of blood flow in the legs. So the feet wounds, they are likely to heal slowly, contributing to the gangrene and other complication, while the microvascular complications infect the eye, kidney. In eye, it can lead to retinopathies, cataracts, and glaucoma, and in kidney, it damages the small blood vessel, and excess blood glucose overworks the kidney, resulting in nephropathy, and it can also leads to neuropathies. It damages the peripheral nervous system, and it may result in the decreased sensation for pain or numbness. The feet wound may go undetected, get infected, and it may ultimately lead to the gangrene or limb amputation. So coming to the epidemiology of the diabetes mellitus, according to the World Health Organization, in 2022, 4% of adult age between 18 years and older were living with the diabetes, and there was an increase in prevalence of diabetes from 7% to 7% as compared to the 1990. More than 59% of adult age 30 years and over living with diabetes were not taking medications for their diabetes in 2022. Diabetes treatment coverage was lowest in low and middle income countries. This is the bar chart which is showing the share of people with diabetes according to 2024. So we can see that the most number of the patients are from the North America, while the South Asian population contributes to 10.72% of the patient of the diabetes worldwide. The prevalence of diabetes in Pakistan, according to 2024 data, there were around the prevalence of diabetes in Pakistan among age 20 to 79 is 31.4%, which is basically a very high prevalence, and it is shown by the very dark red color in the map. So death from diabetes by type 1980 to 2021. So we can see that in 2021, in the world, the vast number of diabetes, about 1.6 million deaths were attributed because of the type 2 diabetes mellitus as compared to the type 1 diabetes mellitus. The type 2 diabetes mellitus is shown by the dark red color, while in Pakistan, again, around 40,000 deaths were reported due to diabetes mellitus. The prevention of diabetes is the most important thing, and it is the mainstay of the treatment, and it revolves around the primary, secondary, and tertiary prevention. So again, the primary prevention is lifestyle modifications are very mandatory for the patients of diabetes, making healthy food choices to maintain a healthy weight. Weight reduction is an important aspect of the treatment of the diabetes. Then monitor blood sugar, adequate quality sleep, stress management, limited alcohol and quit smoking, and regular health checkup. And as we have already talked about the diet of a diabetic patient, so they must include whole grains, vegetables, protein source, and healthy fats and foods in their diet, and they should avoid the ultra processed foods and sugary foods, bakery product, and excessive salts. The secondary prevention includes the screening of high-risk individuals, as we have talked about in the guidelines for this, that who should be screened for diabetes. Adherence to the treatment is very important. Maintain good glycemic control, maintain ideal weight, and blood pressure monitoring is an important, and periodic health checkups to prevent complications. The tertiary prevention includes screening for eye problems and screening for renal problem to avoid the nephropathies and retinopathies, and foot care is important. So the Global Diabetes Compact in April 2021, WHO launched the Global Diabetic Compact, a global initiative aiming for sustained improvement in the diabetes prevention and care, with a particular focus on supporting low and middle income countries. There is a globally agreed target to halt the rise in diabetes and obesity by 2025. The vision of this Global Diabetes Compact is that the WHO Global Diabetes Compact has the vision of reducing the risk of diabetes and ensuring that all people who are diagnosed with diabetes have access to equitable, comprehensive, affordable, and quality treatment and care. The work undertaken as a part of the compact will also support the prevention of type 2 diabetes from obesity, unhealthy diet, and physical inactivity. So these are the engagement structure, which include the WHO Global Diabetes Compact Forum, people living with diabetes, engage the private sector, engagement of the regions and members of state, and technical advisory group on diabetes. So the first ever global coverage targets for diabetes adopted at the 75 World Health Assembly. The 5 new targets which were set to be achieved by 2030 are that 80% of people with diabetes, they should be diagnosed. 80% of people who are living with diabetes have good with 80% of people who are living with diabetes and who are and they should be diagnosed, and once they are diagnosed they should have a good glycemic control. 80% of people with diagnosed diabetes have a good control of blood pressure as well. 60% of people with diabetes of 40 years or older should receive statins, and 100% of people with type 1 diabetes have access to affordable insulin and blood glucose self-monitoring. So the World Diabetes Day is basically celebrated on 14th of November to raise awareness about the diabetes and to show harmony among the patients who are already suffering with the diabetes. Coming to the multiple choice question. So the first MCQ is a 19-year-old female presented in outpatient department with the symptoms of extreme thirst, increased hunger, dry mouth, frequent urination, and unexplained weight loss from the last 2 months, sorry. She reported a prior history of diabetes diagnosed 1 year ago, managed with the diet control. She reports fasting glucose in the range of 150 to 230 mg per DL. She checked her blood sugar before breakfast occasionally and report blood glucose usually over 200. Most likely cause of the symptoms are due to A. Gestational diabetes mellitus, B. Malnutrition induced diabetes, C. Steroid induced diabetes, D. Type 1 diabetes, E. Type 2 diabetes. Yes, the right answer is type 1 diabetes. The second MCQ is a 50-year-old man present with a poorly controlled diabetes developed a painless non-healing ulcer on the plantar surface of his foot. Sensation is reduced. Which factor most likely contribute to this ulcer? A. Peripheral neuropathy and ischemia. B. Deep vein thrombosis. C. Vitamin C deficiency. D. Fungal infection. E. Drug reaction.
A.
Yes, A is the right answer. This is due to the peripheral neuropathy and ischemia as a complication of uncontrolled diabetes. The third MCQ is a 25-year-old 28-week pregnant female presented in the gynecological and obstetric outpatient department with a symptom of increased thirst, fatigue, and increased urination over the last 1 month. She gave a positive family history of diabetes. The most likely cause of this symptom is A. Gestational diabetes, pre-diabetes, C. Steroid-induced diabetes, D. Type 1 diabetes, E. Type 2 diabetes.
A.
Yes, A is the right answer. This is a scenario of gestational diabetes. Fourth, Mr. Riley, a 50-year-old male, had diabetes mellitus for the past 10 years. His glycosylated hemoglobin is 8% and is an oral diabetic medication. Upon his recent routine checkup in the endocrinology clinic, the physician advised him to exercise, maintain his weight, foot care, and regularly walk. Which of the following type of diabetes in which primary prevention has limited scope? A. Gestational diabetes. B. Malnutrition-induced diabetes. C. Steroid-induced diabetes. D. Type 1. E. Type 2.
Delta.
Yes, D is the right answer.
Delta.
Type 1 is basically has a genetic predisposition. So the fifth MCQ is a community health survey in an urban area shows that 14% of adults have diabetes and 9% are unaware of their diagnosis. What is the most important public health action to reduce the burden of undiagnosed diabetes? A. Increase tertiary care hospitals. B. Introduce population-wide glucose screening campaigns. C. Screen only symptomatic individual. D. Focus on insulin distribution. E. Restrict carbohydrate intake by law.
C.
Beta.
Yes, B is the right answer because we need to introduce population-wide glucose screening campaigns. The sixth MCQ, in a low resource district, 30% of the diabetic patients do not adhere to treatment due to the cost and poor access to care. What public health approach would most effectively address this issue? A. Subsidize essential diabetic medication through government programs. B. Conduct more awareness campaigns. C. Increase private clinic licensing. D. Encourage traditional healers to manage diabetes. Implement a sugar-free diet.
B.
Alpha.
Yes, the right answer is A, as there are patients are not adherent to the treatment. So we need to subsidize essential diabetic medications through government programs because patients are not adhering to treatment due to the high cost. A 45-year-old male presented in the outpatient department with the symptoms of tingling and numbness in the feet, leg cramps, weight gain, extreme thirst, increased hunger, dry mouth, frequent urination for the last 2 years. He reported a positive family history of diabetes. He recently shows report of the fasting glucose in 230 mg per DL range. Most days, and HbA1c at a level of 8%. A most likely cause of this symptom is due to A. Gestational diabetes, pre-diabetic, C. Steroid-induced diabetes, D. Type 1 diabetes, E. Type 2 diabetes.
E.
Yes, E is the right answer, type 2 diabetes. The eighth MCQ is a population-based intervention aims to reduce diabetes incidence by building safe walking tracks, restricting junk food advertisements in school, and promoting healthy canteen menus. This represents which level of prevention? A. Primordial, B. Primary, C. Secondary, D. Tertiary, E. None of the above.
A.
Yes, primary. This is primordial A. Primordial is the right answer. The ninth MCQ is Mr. Ahmed wants to conduct a population-based study to determine the prevalence of diabetes mellitus type 2 in ABC population. Which screening test is recommended as best for the epidemiological surveys? A. Blood urea. B. Glycosylated hemoglobin. C. Lipid profile. D. 2R values after 75 gram oral glucose. E. Urine examination.
E.
The right answer is D. 2R value after 75 gram glucose. The last MCQ is during a primary care clinic audit, only 40% of the diabetic patients have controlled HbA1c levels. What is the best public health strategy to improve the glycemic control in the community? A. Provide free glucometers. B. Conduct health education and self-management programs. C. Open more tertiary care hospitals. D. Provide insulin to all patients. E. Annual screening for complications only.
B.
Yes, B is the right answer. Conduct health education and self-management programs. So this is the key to the MCQs. These are the references which have been used in this presentation. This is the official channel of the Institute of Public Health where the recording of this presentation will be uploaded. And thank you for your patient listening.
Thank you very much, Dr. Ayesha. It is a wonderful presentation, and I must appreciate all the participants, especially Dr. Amna Zaman, Dr. Kamran Ijaz, Dr. Temia, Dr. Amna Khalid, for your own professional growth and learning. So it is so heartening to see that all the students and learners, they are taking care of their own self-learning by joining the classes early in the morning every day and making full use of their time. This most important topic that has been presented today is, as we concerned about NCDs and the rising trend of diabetes in Pakistan. As you all know, that this increase would cause a significant complications and disease burden in future, and the projections have already shown that after 2030 and then on 2050, the most of the diseases would be of NCDs, and that phenomena can be stopped if relevant primary healthcare interventions can be made, not only planned, implemented, but also evaluation should be done in order to get the best practices implemented in Pakistan. With this objective in mind, today's presentation is one of an important planning for the future too. So it is not only the learning, the listening of good ideas, but I am very happy to see many important planning points and the planning dialogues that can be based on today's presentation. So very well done, Dr. Aisha. And I hope that one of the policy dialogue we would uh, be conducting on diabetes, as we have done it previously, but there should be series of policy dialogues on diabetes, its complications, primary healthcare level approach, and how can we decrease the disease burden. So these are my inputs, and I am really happy, and the each day is started with a feeling that we have learned something, and may Allah increase our knowledge. And I would end here with the dua of the last prophet Hazrat Muhammad sallallahu alaihi wasallam, Rabbi zidni ilma. Jazakallah khair.
Okay. And thank you so much, ma'am. Thank you so much.